Um, so it is my distinct pleasure and honor to introduce Dr. Geffen Krane. He received his MD and PhD from Cornell and Rockefeller University combined program, and then complete his anatomic pathology residency at Brigham and Women's Hospital, Harvard Med School, where he was elected chief resident. Then he stayed for his cytopathology fellowship under the mentorship of Dr. Sebas, and was a faculty at Brigham for over 20 years, where he served as the Associate Director of Cytopathology and Chief of Head and Neck Service. So after being on the East Coast for many years, Dr. Krane saw the light and decided to move to the West Coast, where he recently, he's currently a full professor at UCLA School of Medicine and Director of Cytopathology Fellowship Program. He has published extensively in the field of cytopathology and head and neck pathology, and is on multiple editorial boards and has served on national and international committees, including the Bethesda System for thyroid cytopathology, and most recently the Milan System for salivary gland cytopathology that he'll talk about today. I also like to mention that, you know, Dr. Krane is very kind to give this talk on his wedding anniversary today. So I just want to give him a big thank you from the UW pathology community. So please mute your mic during this time. If you have questions, please just submit them via through the chat function, and I'll read those questions at the end of the talk. So now I'm going to turn it over to Jeff.
Well, thank you very much for that introduction, Eric. Eric and I go way back to our days at Brigham and Women's Hospital together, and it was a pleasure training Eric during his time there. Of course, I had originally hoped to meet all of you in person, but I'm glad to have the opportunity to speak with you this afternoon, at least via Zoom. And as for it being my wedding anniversary, it is true. It's my 31st wedding anniversary, which is very nice, but it also makes me feel really old. Anyway, without further ado, I'm going to talk today about one of my favorite topics, which is salivary gland fine needle aspiration. I think this is a very challenging area in cytopathology, and we're really going to focus on two specific aspects of salivary gland FNA during the next hour. I'm going to talk with you about the newly proposed Milan system for reporting salivary gland cytopathology. It's been out now for about 2 years. And then I'm also going to talk about ancillary testing and its increasing role in the diagnosis of salivary gland tumors, but we'll be specifically talking about the role of ancillary testing within the context of salivary gland fine needle aspiration cytology. I have no financial disclosures to make with regard to the content of my talk. We'll skip over that. Benefits of a uniform reporting system for salivary gland FNA. You know, I think we can think of this in similar terms to the overall benefits of any uniform reporting system within cytopathology. I think certainly the real paradigm here, the archetype for doing this successfully is the Bethesda system, particularly the Bethesda system for thyroid cytopathology, which has really been a resounding success. When you have uniform reporting systems, they really facilitate having improved communications. You know, one pathologist is going to be saying the same thing as the next pathologist for the most part, so that when we're speaking, our clinicians and our patients will understand what it is any one of us is saying, and when our reports go out to other institutions, that will facilitate understanding what information we're trying to convey in our reports there as well. So there's improved communication. The hope is certainly to improve patient care by providing standardized risk of malignancy data based on the diagnostic category that each specimen falls into, and uniform clinical management approaches, which of course will be individualized for each patient, but at least serve as a useful starting point for thinking about appropriate management. By having uniform reporting, the hope is that that this will facilitate cytologic histologic correlation, as well as research studies and sharing of data across institutions, And both of these will really serve the function of improving the performance of whatever uniform reporting system you have, or in this case, the Milan system. So I think it's understood that this is really a first effort, and the hope is that it will improve over time. So a little bit about the background of the Milan system. Again, this is kind of following in the wake of the Bethesda system for thyroid FNA. There was a group that was first assembled in 2015 to assess the possibility of a uniform reporting system for salivary gland cytopathology. This group is jointly sponsored by the ASC, the American Society of Cytopathology, as well as the International Academy of Cytology. The goal is to produce a practical, user-friendly, and internationally accepted classification system. So it's not limited to the U.S. in the way that the Bethesda system is, or hopefully there won't be competing systems. The goal certainly was to make this system as evidence-based as was possible at the time of development. And as I mentioned before, it was really anticipated that there would be further refinement of the Milan system over time as we get data and further studies to see how it performs in practice. Here's a photograph from an early meeting of some of the main participants. You can see there I am, kind of in the back of the room. I'd say that's kind of an appropriate positioning for what my role was in the development of the Milan system. I certainly was involved, but I wouldn't say that I was a major player. I think the two individuals who really deserve the vast majority of the credit for developing the Milan system were Dr. Diana Rossi from Rome, Italy, and Dr. Bill Faquin, who I'm sure most of you are familiar with, who practices at Mass General Hospital in Boston. So the atlas, after several years of effort, was published in early 2018, so it's been just over 2 years ago now. Ultimately, there were 45 contributors from 15 countries, predominantly cytopathologists, but also including surgical pathologists, molecular pathologists, as well as ENT surgeons. The resulting classification scheme, I think, is a little bit complex in certain ways. Again, certainly inspired in some ways by the Bethesda system for reporting thyroid cytopathology, but it has a couple of layers of increased complexity that aren't there in the thyroid reporting scheme. So it looks at first blush like it's a 6-tiered scheme, but in reality, one of the tiers is subdivided, so it's really a 7-tiered scheme. So the categories are non-diagnostic, non-neoplastic, atypia of undetermined significance, or AUS, the neoplasm category, which is further subdivided into a benign category, as well as the so-called SUMP category, which stands for salivary gland neoplasm of uncertain malignant potential, the suspicious for malignancy category, and then the malignant category. So I'm going to spend the initial part of this talk just reviewing some salient facts about each of the diagnostic categories, and then we'll kind of go on from there. So starting with the non-diagnostic category, this category is intended to represent, to be used for aspirates that qualitatively or quantitatively provide insufficient diagnostic material to provide an informative interpretation. So as you might imagine, that's going to include things that might be acellular or have very poorly preserved material where there's so much artifact that it precludes any kind of meaningful evaluation of the specimen. But I would also note that this is going to include aspirates that are comprised purely of benign elements in the setting of a defined mass, which is going to be most instances. So most of the time, if you get an aspirate, that could be quite cellular, as you can see in the image that I have associated with this slide. You see these nice grape-like clusters of serous acinar cells. You can see a few clusters of ductal type cells in the background. You can see some very intimately associated adipose tissue. This is, the appearance of normal parotid gland on an FNA specimen. And in most instances, if there's a discrete mass in the gland, this is really going to represent basically a miss of the targeted lesion. And as a result of that, it would be appropriate to call such an aspirate non-diagnostic. When it comes to aspirates that contain cyst contents that lack epithelial elements, it's important to characterize what the nature of the cyst content material is. So if you have non-mucinous cyst contents, that would be appropriately categorized as being non-diagnostic in the absence of epithelial elements as well. Mucinous cyst contents are going to be handled in a somewhat different manner, and we'll talk about that a little bit more. Some more tidbits about the non-diagnostic category. At this point, there really are no clearly defined adequacy criteria that have been established for a salivary gland FNA. There is a statement in the atlas, which I personally don't find very helpful, that says that it's recommended until more data is available, a minimum of 60 lesional cells could be used as a reasonable and objective measure of adequacy. I think that's inspired by the 6 group of 10 rule that we use in thyroid FNAs, but I don't think it really ends up being terribly meaningful in this context. And I have to say that I pretty much ignore this statement in rendering my diagnoses of salivary gland FNAs using the Milan terminology. One of the reasons I ignore that is, you certainly don't need 60 atypical cells if you're going to call something, for example, AUS. So even if you see just a handful of cells that have some significant cytologic atypia, you're probably going to want to call that something other than non-diagnostic. If they're very limited in numbers, then AUS is probably going to be an appropriate place to put it. In addition to that, you can have, we mentioned cysts. The non-mucinous cysts are appropriately put into the non-diagnostic category, but mucinous cysts without epithelium should go into the AUS category. When you have an abundance of inflammatory cells, even in the absence of an epithelial component, that would be appropriate to put such an aspirate into the non-neoplastic category. And when you have abundant matrix material, with very limited or no epithelial component, those aspirates also are not going to ultimately end up in the non-diagnostic category. They should probably end up either as being called AUS or neoplasm benign if it's diagnostic, for example, of a pleomorphic adenoma. Moving to the non-neoplastic category, these are specimens that lack evidence of a neoplastic process. I already mentioned aspirates where you might see abundant inflammatory material. For example, the image shown here, you can see a lot of neutrophils in the background here, and then there's this stone fragment that's present as well. So this is an example of an acute sialadenitis in the setting of sialolithiasis. So that would be an inflammatory aspirate that would be appropriately characterized as being non-neoplastic in nature. Metaplastic processes would also fall into the non-neoplastic category. Reactive epithelial changes, all of these things would be appropriately called non-neoplastic. In addition to acute sialadenitis, chronic or granulomatous sialadenitis could fall into this category. Sialadenosis is a diffuse enlargement of the salivary gland. This could appropriately be put into the non-neoplastic category. But again, I would caution that most instances where you just get normal salivary gland elements, which is typically what you see in a case of sialadenosis, most of those are going to belong in the non-diagnostic category unless you're really going in with a high clinical suspicion for the diagnosis of sialadenosis. I wouldn't usually fall back on that. Reactive lymph nodes can be called non-neoplastic, although in most instances it's going to be preferable to have some kind of flow cytometry to confirm the benign nature of the process. Often you're going to want to have clinical radiologic correlation to make sure that something that you're calling non-neoplastic is truly representative of the underlying lesion and not something that might be, for example, adjacent to a neoplasm. Moving on to the AUS category, these are going to be specimens where you can't entirely exclude the possibility of a neoplasm. Much like, again, the AUS category in the Bethesda system, it's going to be a heterogeneous category that can have a variety of findings that might lead you to an AUS diagnosis. The expectation is that most of these will either represent some kind of a benign reactive atypia or instances in which there's a neoplasm that has been inadequately sampled. There certainly can be a role for calling things AUS when your ability to evaluate them is compromised by significant artifacts such as air drying or blood clotting artifact. And the hope is that the AUS category will be used relatively infrequently. And again, in parallel with the Bethesda system, the recommendation is that the AUS category should not exceed 10% of all salivary gland FNAs. I think in contrast to what some laboratories have been confronted with the Bethesda system in the AUS category, I think the 10% cutoff for AUS in the Milan system is not going to be a particularly difficult threshold for most laboratories to stay under. I don't think too many aspirates end up in the AUS category, at least from my experience and most of what's been published to date. The AUS category, as I mentioned, are aspirates where you can't exclude the possibility of a neoplasm. We've talked about most of those scenarios already, and I want to just hit again on the point that mucinous cysts, where you have limited or no epithelial component, should go into the AUS category. And this image here shows an example of such an aspirate where you can see abundant mucin in the background. There are some scattered macrophages admixed as well. And here, the differential diagnosis would include something like a mucocele or a mucus retention cyst. But our real concern is that you might be dealing with a mucoepidermoid carcinoma. And as I'm sure most of you are familiar with, mucoepidermoid carcinomas frequently are cystic, particularly the low-grade mucoepidermoid carcinomas, where the mucinous component tends to predominate. And there is a real possibility in a low-grade mucoepidermoid carcinoma of simply aspirating out mucinous contents from the neoplasm without getting a good representation of the epithelial component. And using the AUS diagnosis allows us to avoid completely missing these tumors in that circumstance. Moving on to the neoplasm categories. So the first one again is benign neoplasm. This is reserved for clear-cut examples of benign neoplasms. So here you can see, just a classic pleomorphic adenoma on the lower right-hand image, where you have the fibrillary chondromyxoid matrix material with myoepithelial cells embedded within the substance of the matrix material. And then on the left, you can see an example of a Warthin tumor with sheets of oncocytic epithelial cells and small lymphoid cells dispersed in the background of the aspirate. So both of these are classic examples of both a pleomorphic adenoma and a Warthin tumor. Those are going to be the most common neoplasms overall that are benign, and those are going to be the ones that are going to account for the vast majority of tumors that are going to fall into this neoplasm benign diagnostic category. The category that's more challenging to us, and the one that we're really going to spend a lot of time thinking about as we go through the rest of this talk, especially when we do get to thinking about ancillary testing, is the SUMP category. So again, this stands for salivary gland neoplasm of uncertain malignant potential. These are going to be instances where we recognize that we're dealing with a neoplasm, but we can't get to the diagnosis of a specific entity. And even more importantly, our differential diagnosis includes both a benign tumor at least one example of a benign tumor and at least one example of a malignant tumor. So we're not sure if it's benign or malignant based on what we're seeing. And here the thought is that there's really three morphologic variants that are going to be most frequently encountered. Those are going to be basaloid aspirates, which tend to be really the most problematic differential diagnosis overall in salivary gland FNA, very challenging aspirates for us. And then oncocytic aspirates, the upper right-hand image shows an example of an oncocytoma, or clear cell aspirates, and the lower right-hand image is an example of an acinic cell carcinoma. And especially the oncocytic and clear cell patterns can frequently overlap with each other, both morphologically and in terms of the entities that enter into the differential diagnosis when we're thinking about those. So that's the SUMP category. Moving from there, we have then the suspicious for malignancy category. These are going to be aspirates which are highly suggestive of malignancy but are not definitive. And I think it's important to point out that the suspicious for malignancy category in the context of the Milan System is just a little bit different than we often think of a suspicious for malignancy diagnosis in other areas of cytology. I think one scenario is probably fairly similar to what we might think of elsewhere, and that's where you might have a high-grade carcinoma where you just have very limited sampling. So there's either quantitative or qualitative limitations that are preventing you from feeling 100% certain that you're dealing with a malignancy, or perhaps even 100% certain that you're dealing with something that's neoplastic, but you're very concerned that it's a carcinoma. So usually that's going to be something that has high-grade cytomorphologic features, but it's poorly sampled in some fashion. The other context that's a little bit different when we're thinking about suspicious for malignancy is sorry, got distracted by the chat, is when you're certain that you're dealing with a neoplasm and you have features that you are very concerning for malignancy, but you can't be definitive about it being malignant. So this is kind of the next step up, if you will, from the SUMP category. So I think one way to think about this, again, in the context of, say, the basaloid neoplasms is, you know, you might have, say, a basaloid neoplasm that represents a cellular pleomorphic adenoma, and you're able to say that with certainty. That would be in the benign neoplasm category. Then if you have, say, a basaloid neoplasm where your differential diagnosis includes a basal cell adenoma and an adenoid cystic carcinoma, but you're favoring that it's basal cell adenoma, that would appropriately go into the SUMP category. If, on the other hand, you had that same differential diagnosis, but you thought it was more likely to be adenoid cystic carcinoma, then it would be appropriate to put that into the suspicious for malignancy category. And then still later, if you had an aspirate and you were totally sure that you're dealing with an adenoid cystic carcinoma, you would put that into the malignant category. All right, so that's the suspicious for malignancy category. Then if we move on from there to the malignant category, this is relatively straightforward. In terms of the definition, these are ones that are diagnostic of malignancy. Usually these are going to represent primary salivary gland epithelial derived malignancies, but it could include other malignancies like lymphomas, sarcomas, or metastatic disease. Here you can see two examples. The upper right-hand image is an example of a salivary duct carcinoma where there's, you know, marked cytologic atypia. And then the lower image is, you know, kind of a classic cytomorphologic presentation of an adenoid cystic carcinoma. I would also just point out that there's a recommendation with the malignant category that if possible, you should try to distinguish between low-grade carcinomas and high-grade carcinomas. And when we'll talk a little bit later about management, and we'll talk about why that can be a distinction that's worth making. Okay, so let's put this all together. Here's a table that summarizes all the features of the terminology and reporting, our diagnostic categories, the associated risk of malignancy, and the typical management. And you can see that for the most part, the management strategies for neoplasms are largely going to be surgical in most instances. while the instances where you're not sure about a neoplasm may involve repeat FNA or clinical and radiologic follow-up. I will point out when we look at the risk of malignancy that for the most part, in the indeterminate categories, there's a trend towards higher degrees of malignancy. But some of the risks of malignancy are not as straightforward as you might expect. So for example, a benign neoplasm diagnosis is associated with a very low risk of malignancy, which is good. That's what we would hope for. But the non-neoplastic category actually is associated with a higher risk of malignancy. And again, that's presumably because you may actually not be sampling the lesion of interest when you think you're dealing with a non-neoplastic process. And non-diagnostic specimens also are associated with a rather high risk of malignancy on the order of 25%. And again, that just represents that these are probably mass lesions that just have not been adequately sampled. Okay, so that's an overview of the Bethesda system. Now we're seeing many more publications around the Milan system. I think I said Bethesda mistakenly. I just want to provide just a taste of some of the studies that are beginning to come out. So these are all retrospective studies at this point. That's important to point out. We don't really have prospective data yet with significant follow-up. But this table just summarizes how each of the categories is being used with what degree of frequency. And the main thing I want to point out here is that you can see that overall the AUS category is being used only in about 3% of all aspirates. The benign neoplasm category is comprising somewhere between 35 and 40% of all aspirates. Again, most aspirates are going to be from the parotid gland, the superficial lobe of the parotid gland, and pleomorphic adenomas and Warthin's tumors are going to account for most aspirates. So it's not surprising that that's a high frequency diagnosis, and about 10% of all aspirates are going to be malignant. With regard to interobserver reproducibility, this is a nice study from Dr. Layfield and his colleagues, where they had 3 observers reviewing over 400 cases and categorizing them using Milan categories. The only thing they did in addition to that was to try to distinguish the low-grade malignancies from the high-grade malignancies. So you can see they've subdivided the malignant category. Overall, they have only fair agreement amongst the observers. The areas where agreement was better, not surprisingly probably, are in the benign neoplasm category and with the high-grade malignancies. So those are pretty reproducible across different observers. Then we kind of get somewhat less agreement in the non-diagnostic category. And then we actually have rather poor agreement if we look at particularly those indeterminate categories, AUS, SUMP, suspicious for malignancy, but also in the low-grade malignancies. They can be very challenging and difficult to distinguish from neoplasms that are not malignant in many circumstances. So there's certainly room for improvement there, and probably room for having other techniques available to us that could help us refine our diagnoses beyond what we can do based purely on morphology. Looking at risk of malignancy, again, these are retrospective data. I'm not going to dwell on this other than to say that so far it looks like the anticipated risks of malignancy that have been put out by the Milan system seem to correlate pretty well with what people are seeing in their different practices. There's been some interest in whether different patterns of SUMP represent different risks of malignancy associated with them. There have been already a few different studies on this topic, and without dwelling on it, I would just say that at this point there are conflicting data as to whether any one particular pattern of SUMP, whether it be oncocytic or squamoid or basaloid, is associated with a higher risk of malignancy than another pattern. Okay, so let's turn our attention now to ancillary testing, and this is what we'll focus on for really the balance of the hour here. And when we're talking about ancillary testing of salivary gland FNAs, Obviously, it's important for us to know, what are the tests that we're talking about, which entities are they most helpful in diagnosing, and when should we think about using them and applying them in our everyday practice. Before we get into the weeds of that too much, I want to just offer up a few words about the surgical management of parotid tumors. I think it's important that we all kind of understand where this is coming from on a clinical management perspective. Again, I mentioned that most salivary gland FNAs and most tumors actually arise in the superficial lobe of the parotid gland. And it's important to remember that the facial nerve is a key anatomic structure with regard to the parotid gland. It's the facial nerve coursing through the gland that divides the superficial lobe of the parotid from the deep lobe of the parotid. And in terms of determining extent of surgery, a lot revolves around the ability to preserve facial nerve function and the potential morbidity associated with either damaging or sacrificing the facial nerve. So this is a key parameter to consider. And the thing to remember here is that the distinction in terms of management is not between benign tumors and malignant tumors, but it's really between benign tumors and low-grade carcinomas being treated in a similar fashion and high-grade carcinomas being managed more aggressively. So that's really the important distinction to make from a surgical management perspective. Usually the benign tumors and the low-grade carcinomas will be treated in the same way, a superficial parotidectomy where essentially the mass is removed with a thin rim of normal uninvolved tissue around it. In a subset of patients, especially say a poor surgical risk patient who might have something like a Warthin's tumor, observation may be an option, particularly for some of the benign tumors. For high-grade carcinomas, those patients are more likely to have a total parotidectomy. Many of them will also have neck dissections done, and most of them typically will also have radiation therapy done as an adjunctive treatment as well. Okay, so if we think about, where in the Milan System algorithm or subset of categories is ancillary testing likely to be most helpful to us, I think the obvious answer to think about would be in the indeterminate categories. If we can resolve the uncertainty associated with these categories and make a more definitive diagnosis, that would seem to be a desirable thing to do. First, we can think about this in the context of the AUS category, where perhaps you might be able to move something from AUS into either a non-neoplastic or a benign neoplasm category, potentially. I think the problem with the AUS category is these tend to be very limited specimens. So I think in most instances, doing some kind of ancillary testing is unlikely to be particularly helpful for most instances. More fruitful is likely to be those aspirates that might otherwise end up in the SUMP category or in the suspicious for malignancy category. Here, the goal would be to move them, these aspirates, into a more definitive diagnostic category, either the benign neoplasm category or the malignant category, and that could certainly have management implications for the patient. So here's 4 aspects. These are all basaloid neoplasms that we can see, and based purely on the morphology alone, I can't tell you which of these tumors represents what entity, and really without some kind of additional studies done on these, I really wouldn't be able to get beyond the SUMP diagnosis. So can we move beyond that in a specimen like this, and if so, how? So the ancillary tests that we're thinking about in this context really fall into these categories here. Historically, there's the very low-tech way, which is purely cheap histochemical stains. Of course, we tend to rely much more on immunohistochemistry these days, and the immunohistochemical stains fall into a couple of different categories that we'll discuss in some more detail. And then there are techniques that are localized more around identifying the underlying genetic alterations that have been determined to be associated with many salivary gland tumors now. So FISH, cytogenetics, or next-gen sequencing can all be used to identify underlying genetic alterations in many salivary gland tumors. Flow cytometry, I'm not going to talk about that in any further detail, but I will just highlight that this is an important ancillary test available to us when you have a predominantly lymphoid process, either involving the salivary gland directly or involving one of the lymph nodes that can be very intimately associated with the salivary gland, particularly in the setting of the parotid gland. So histochemical stains here, there's really two stains that we might use in our everyday practices. The first is in the diagnosis of actinic cell carcinoma. I mentioned these can have either a clear cell or oncocytic appearance. Here's an example of an actinic cell carcinoma. They often have this kind of fairly generic looking, slightly bubbly appearance to the cytoplasm with a lot of cytoplasm. What you really need to make a definitive diagnosis of an actinic cell carcinoma is to clearly demonstrate the serous acinar differentiation. Usually that's most easily done with a PAS with diastase stain. So I think if you have either an oncocytic or clear cell rich salivary gland neoplasm, it can be very helpful to get a cell block in those instances. And what we usually find with actinic cell carcinomas when we do this is that just on a routine H&E, often you can get that amphiphilic granular cytoplasm in the serous acinar cells to the point where you can readily recognize that you are dealing with serous acinar type cells on a routine H&E, and you don't even really need to resort to the PASD. But if you do, you can do a PASD stain to highlight the zymogen granules. So that's one of the histochemical stains available to us. The other histochemical stain that we use with some frequency is a mucicarmine stain, particularly in the context of trying to make the diagnosis of mucoepidermoid carcinoma. For the low-grade mucoepidermoid carcinomas, usually the low-grade mucoepidermoid carcinomas, the mucinous component predominates in these tumors, and it's usually fairly readily identifiable on smears when those cells are there. So you can see the mucin-bearing cells present here without the assistance of any additional stains. It's the high-grade tumors where you may need to resort to using a mucicarmine stain. Here's a tumor that looks overtly malignant, and your differential diagnosis is likely to be with something like a non-keratinizing squamous cell carcinoma, perhaps metastatic to this site. And this is a circumstance where in the high-grade tumors, the squamoid cells tend to predominate more, and the mucinous epithelial cells can be very focal in their presentation, and a mucicarmine stain can be very helpful in that context. Turning to immunohistochemical stains, I think the ones that have historically been available to us often just kind of reinforce our impression of what the type of differentiation is of the cells that we're looking at. So we can use like panels of myoepithelial cells to kind of highlight, say, a biphasic growth pattern, such as you can see in this tumor where the myoepithelial cells are positive and the ductal cells are stained negatively. The only thing I would mention as a pointer when you do stain for myoepithelial cells is regardless of what stains you like to use in your laboratory for myoepithelial differentiation, I would encourage you to use a panel of markers. These tumors can be quite idiosyncratic from one example to another in terms of which markers may actually stain a given tumor. Ultimately, though, these these kind of broad panels of myoepithelial markers, often they just kind of highlight what architectural patterns might be underlying the tumor. They can help shape your differential diagnosis, but they usually don't have the kind of specificity that you need to get to a specific diagnosis. So these are 4 examples here of salivary gland tumors that all have biphasic, ductal, and myoepithelial appearance components to them. And it's really how those elements relate to one another and what types of matrix material are present that helps us in distinguishing these tumors from one another. It's not enough just to say, yes, there are myoepithelial cells present in any of these tumors. So moving on from these kind of more general immunohistochemical profiles to panels of markers that seem to have some greater specificity for specific entities. There are some tumors that have fairly characteristic immunohistochemical profiles that you should be aware of. So for example, secretory carcinomas usually stain with S100 and mammoglobin. That's not entirely specific for secretory carcinoma, but it is the kind of characteristic staining pattern that we tend to see with these tumors. I've highlighted here salivary duct carcinoma because I think in particular the presence of androgen receptor immunoreactivity is something that I look for and basically insist on having before I'm willing to make a diagnosis of a salivary duct carcinoma. Here's a couple of examples of salivary duct carcinoma on FNA. They're clearly examples of high-grade malignancies. A clue to the diagnosis often can be the presence of a granular necrotic tumor diathesis in the background. That's something that we typically will encounter with salivary duct carcinomas. But as I mentioned earlier, really want to see the presence of androgen receptor staining to confirm that you're specifically dealing with a case of salivary duct carcinoma. A subset of these tumors will also overexpress HER2. So moving on from there, this is where things get really exciting. I mean, there have been so many developments, and we just continue to have a lot of exciting developments in the area of salivary gland pathology. We are understanding the underlying genetic alterations that give rise to many of these tumors. We just continue to make a lot of progress in this regard. And for some of these genetic alterations, we have to rely on molecular techniques such as FISH to make the diagnosis definitively at this point. But for some of these entities, we now have surrogate immunohistochemical markers that we can use in lieu of actually doing molecular testing. And I've highlighted some of those here. Those are the ones that are bolded here, ones that have surrogate immunohistochemical markers for the genetic alterations that we see. But I just want to point out that pleomorphic adenoma, adenoid cystic, mucoepidermoid carcinoma, acinic cell carcinoma, these are some of the most common salivary gland tumors that we encounter, and we now recognize all of these as having characteristic genetic alterations associated with them. So with pleomorphic adenoma, if you have the absolute classic appearance with the fibrillary chondromyxoid matrix material, the myoepithelial cells embedded within that matrix, clusters of ductal cells, we don't need any kind of molecular testing or immunohistochemical testing to confirm the diagnosis in such cases. Pleomorphic adenoma gets challenging when we no longer see the characteristic matrix material in abundance, or we see matrix material that puts us in mind of other entities. So here's like a little cylinder that you might think of as possibly representing an adenoid cystic carcinoma, or a spindled tumor that's very cellular, or a tumor that's more plasmacytoid in its appearance. These each will generate differential diagnoses that might make us think about other entities, perhaps mesenchymal tumors or even a plasmacytoma. This is where some type of ancillary testing can be very helpful to us. We've known for a long time, actually, that pleomorphic adenomas have recurrent translocations associated with them, most commonly involving the PLAG1 locus, with a secondary locus being the HMGA2 locus being most frequently involved in pleomorphic adenomas. And we can FISH for these translocations if you do have that available to you. Most laboratories don't, I would say. And it's also been demonstrated that these alterations can persist in patients who have carcinoma X pleomorphic adenoma. So again, identifying PLAG1, HMGA2 alterations can be helpful in rendering a diagnosis of a carcinoma X pleomorphic adenoma. As I mentioned earlier, though, we now have surrogate markers for these translocations as well. And this is something our laboratory looked at in a large survey of surgical pathology specimens, different salivary gland tumors, looking at HMGA2 and PLAG1 expression. And here you can see two examples of pleomorphic adenomas, one overexpressing PLAG1, the other overexpressing HMGA2. And in total, what we found was that with pleomorphic adenomas, about 85% of all pleomorphic adenomas would stain for one or the other of these two markers, and they were highly specific for the diagnosis of either pleomorphic adenoma or carcinoma X pleomorphic adenoma as well. And the carcinoma X pleomorphic adenomas had less sensitivity with these two antibodies. Only about half of those were PLAG1 and HMGA2 positive. We also looked at these markers on cytologic material using cell blocks to try to make the distinction between pleomorphic adenoma and adenoid cystic carcinoma, which can be a challenging distinction for us on cytologic material. So looking at cell blocks from pleomorphic adenomas and adenoid cystic carcinomas, again, we found very similar results, 85% overall of pleomorphic adenomas stained with either PLAG1 or HMGA2. None of the adenoid cystic carcinomas stained with those. Turning to adenoid cystic carcinoma, we've talked about that a little bit. When you have, either the cribriform variant where you have that Swiss cheese-like appearance and the characteristic acellular spheres of matrix material, or the tubular variant where you have more finger-like projections of matrix material, this diagnosis can be very straightforward on cytology as well. But here, the real challenge that we face with adenoid cystic carcinoma is when we encounter a solid variant of adenoid cystic carcinoma. And here's an example of the solid variant where you just see these sheets of baseloid cells. Sometimes they can have marked atypia, but sometimes they can be deceptively bland in their appearance. So that can be a real problem for us, particularly because the solid variant of adenoid cystic carcinoma is actually the most clinically aggressive variant. These tumors may show very little matrix material, or it may be very focally present, as you can see here. That tends to be best demonstrated on the air-dried preparations. Again, we now understand that adenoid cystic carcinomas have a characteristic chromosomal aberration that's associated with most tumors, with translocation involving the MYB gene being most common and involving over 80% of adenoid cystic carcinomas. And that's true whether they arise in the salivary gland or elsewhere in the body. Adenoid cystic carcinomas, regardless of primary site, show this translocation. And there's a surrogate immunohistochemical marker, for MYB, that can be used. It does stain a comparable percentage of adenoid cystic carcinomas. Unfortunately, it seems to not be entirely specific, and in particular can fail you on these baseloid adenoid cystic carcinomas where there's very little matrix material. So just as an example, in this particular study, 4 out of 5 baseloid squamous cell carcinomas, which certainly are in the differential diagnosis, also stained with the MYB stain by immunohistochemistry. So I think the MYB stain, unlike PLAG1 or HMGA2, in practice might be useful as a screen, but can't totally rely on it and may ultimately have to resort to FISH. In that same study, we also looked at MYB along with KIT, which has been touted as an adenoid cystic carcinoma marker. And here we found that the combination of MYB positivity and KIT positivity with PLAG negativity and HMGA2 negativity was very specific for adenoid cystic carcinoma, but lacked sensitivity overall. Okay, so there's a number of these tumors where we do have surrogate markers, and some tumors that are relatively common, like mucoepidermoid carcinoma, as highlighted here, we don't really have a specific surrogate marker. So these also have a characteristic translocation involved with them. It involves the MAML2 gene, but there is no immunohistochemical marker that's specific there. Yes, you can use P63, P40 to identify the presence of squamoid differentiation, but that's not a specific panel. I will also highlight here one other tumor, which I failed to mention earlier, which is a cynic cell carcinoma. And I just want to point out that just the rapid pace of change of our understanding of these salivary gland tumors. And, just in the last year, really, it's been defined that actinic cell carcinomas do have a characteristic translocation involving the vast majority of these tumors, and there appears to be a very promising immunohistochemical marker that seems to be both sensitive and specific for this translocation involving the NR4A3 gene. And then this is more of a proof of concept study, but it just shows that next generation sequencing can also be applied to FNA material. This was taking smears and using them to do next generation sequencing to confirm a diagnosis of polymorphous adenocarcinoma and identifying the point mutations that are associated with that tumor. So returning to the image of all these potential SUMP cases, each one of these is associated with a tumor that has a characteristic genetic alteration with it that if you had the appropriate material in hand, you could potentially get to a more definitive diagnosis. And in some instances, it might represent a benign tumor. Other instances, it could represent an actually quite aggressive tumor clinically. So it can be a very important distinction if we're able to make that distinction. Okay, so resolving diagnostic uncertainty is going to be probably our most useful area for these ancillary tests. What about in areas where we know that something's a benign tumor or know that something's a malignant tumor? Is there a role for ancillary testing there? I think in the neoplasm benign category, while you may potentially be able to use ancillary testing to, for example, make the distinction between something like a cellular pleomorphic adenoma and a basal cell adenoma, there's really not a compelling need to do this. So it might make us feel good, it might make us look good if we can make those distinctions, but from a management perspective, it's not really going to make much of a difference. In the malignant category, I think the story can be a little bit different, and that's because if you'll recall, we have been instructed by the Milan System, and I've told you that it can be important from a management perspective to know whether we're dealing with a low-grade malignancy or a high-grade malignancy. So here's a case that we saw several years ago now that actually came to us from an outside institution carrying a diagnosis of potentially a high-grade mucoepidermoid carcinoma. And I think the thought there was that these vacuoles might represent mucin vacuoles in the cytoplasm of the cells. You can see they do have prominent nucleoli, so you can see where that might have been a reasonable thought. But we were wondering about the possibility of this representing a mammary analog secretory carcinoma. You can see the dense secretory material present here as well. We had a cell block available to us, and it was in fact positive for mammoglobin and S100. We did the ETV6 FISH on this case, and that confirmed the diagnosis of a secretory carcinoma. And these generally speaking are considered to be low-grade carcinomas, and this did in fact have a significant impact on how this patient was managed from a surgical perspective. So I think in the malignant category, in selected instances, it can be important to use ancillary testing to make that distinction. Another role in aspirates that you know is malignant for doing some sort of ancillary testing is for the potential therapeutic implications of some of our stains, as well as diagnostic utility. I mentioned that AR and HER2 can be useful diagnostically in salivary duct carcinomas. These are also very aggressive tumors clinically, and as a result of that, using anti-androgenic agents or Herceptin can be highly desired in the clinical setting with salivary duct carcinomas. Just a couple other words about salivary duct carcinoma very briefly. About half of these do arise as carcinoma ex pleomorphic adenoma, and in those instances, you can pick up the PLAG1 or HMG-GA2 alterations in addition to AR and possibly HER2 alterations. So what should our expectations be with regard to ancillary testing of salivary gland FNAs? I hope that I've convinced you that you can use ancillary tests to minimize diagnostic uncertainty, refine risk stratification, and optimize patient management, and also promote clinician confidence in our diagnoses. But I think it's important for us to also recognize that there are obstacles to implementing these ancillary tests. Does your laboratory have the ability to do on-site rapid on-site evaluation and appropriately triage material for these tests? Do you have the technical expertise? Can you afford the personnel and the actual laboratory costs associated with doing these tests? And they can be fairly laborious as well. So as we kind of put the ancillary tests in the context with the Milan system, I think it's important to point out that while the Milan system recognizes the value of ancillary techniques, it's not proscriptive. It doesn't insist that you do ancillary testing. It just says, hey, these things are out there and they may be helpful to you. But I think the Milan system can also provide a framework for us for thinking about when it might make sense to do ancillary testing and to kind of balance what resources you have available to you, what your clinical expectations and needs are for the patient, and for kind of optimizing your performance of salivary gland FNA. So with that, I'm going to close just by pointing out again, I think the Milan system may have some imperfections associated with it at this stage, but I would encourage you to use it because it does provide a standardized reporting terminology, and it's kind of the best we have right now. And it does provide risk stratification and guidance for clinical management of patients. And I think we can supplement the Milan system with ancillary testing to improve the performance of and increase confidence in our diagnoses of salivary gland FNAs overall, but specifically in the context of the Milan system. And I think overall, what early data we're seeing are pretty encouraging with regard to the use of the Milan system and how it's performing in practice. So with that, there's just a couple of kind of more general references that you could use if you want to explore these topics further, and be glad to take any questions that anyone might have. Thank you very much.
Thank you, Jeff, for such a wonderful talk. So there are a few questions that the audience have, so I'm just going to read them. Would you like to tell us why all these classifications only path-centric and do not include radiologic and clinical criteria in the algorithm? Artificial intelligence will include all these eventually and likely make path-centric classifications less accurate, if not redundant. So these classifications also take our trainings away from holistic thought process. So what do you think of that?
Okay, so there's a couple of ideas here. I think clearly it is very important for us to synthesize all of the information that's available to us. And I think where we're seeing this more actively occurring is in the context of thyroid aspirates, where we are seeing radiologic classification schemes that are arising for the risk associated with different appearances under ultrasound, and as well as the separate cytologic classification schemes. And to some extent, I certainly agree that at some point, ideally, we would like to see some synthesis of the risk associated with the different classification schemes. I think ultimately, right now, I would certainly encourage you as a pathologist to get every bit of clinical and radiologic information one can get as we make our decisions. I don't think that using the Milan system precludes us from looking at what the underlying radiologic material is associated with a lesion. It just doesn't necessarily demand that we have the knowledge level of a radiologist in order to render our diagnoses. And I think the same thing is kind of happening on the thyroid side. Ultimately, right now, it's kind of falling back into the lap of the clinician to kind of synthesize all of this material. But I certainly can envision a role in the future, especially if you start thinking about something like ROM, the risk of malignancy, where you might say, well, this is In the cytologic classification scheme, this is this diagnosis. In the radiologic classification scheme, it has this diagnosis, and you put those together, and there's a certain risk of malignancy that would be associated with it. And I think that may end up being a more powerful way of risk stratifying patients than having these things in their own separate towers. I just don't think we're there yet. As with regard to holistic thought processes, I don't know. I'm kind of a data-driven guy. I certainly still generate broad differential diagnoses. I don't know. I don't think that ultimately settling on some kind of a terminology category to put your diagnoses into prevents you from thinking in a holistic manner. I think more about, well, what is the diagnosis here, or what are my limitations on my diagnosis, and then I go to the Milan system to say, what category would this fit in more? So I think I kind of come to the classification scheme at the end of my process rather than starting from there. So I'm not overly concerned about that aspect of it personally.
Okay, and another question: have there been advances in the use of genomics and transcriptomic of needle biopsies or liquid biopsies of salivary fluid?
Well, that's a very that's an advanced question. As far as I know, I am not aware of work of that sort that's being done in salivary gland tumors. I mean, obviously there is a tremendous amount that's being done just in terms of determining the underlying genetic alterations in these tumors. So I think if you want to call that genomics, then yes, there is. They tend to, a lot of these tumors are turning out to have fairly simple underlying genetic alterations associated with them. To what extent those are being applied in needle biopsies or liquid biopsies, I don't think there really is much there at this point. I think one of the things that's important to remember with salivary glands is that overall these are relatively uncommon lesions. They're uncommon diseases. That also tends to mean that there's not a lot of financial support for doing a lot of expensive research on these things, and there really only are a few labs that really have the resources to devote to this type of research.
Thank you. And another question is, does the diagnosis of secretory carcinoma require EBT6 gene arrangement?
Yeah, so that's an interesting question, and I think you might get different answers from different people. I personally don't think that it's an absolute requirement. I think there are some cases where the constellation of morphology along with S100 and mammoglobin immunoreactivity, I would feel sufficiently comfortable to make the diagnosis without ETB6. But I would say that that's probably a subset of the tumors, and they can have fairly varied morphology. And I would say that in many instances, and I would say this applies to on the SurgPath side as well, we often don't feel comfortable making that diagnosis without some supporting molecular analysis of those tumors. Now, I think it's possible that still remains just being a little bit of an experience factor for us. It's still a relatively new entity, and for many of us, we haven't seen hundreds of these tumors at this point. We've just seen, handfuls. And as we gain more experience, I think we may gain increasing comfort in making that diagnosis without resorting to molecular testing.
And I have a question for you, Jeff. So,
yep.
It's coming from like a cytologist perspective. When I look at these lesions, I'm usually thinking, okay, how much surgery do I want them to do?
Right.
Sometimes, when I look at some of the lesions, I know they're neoplastic, but I can't really put them under like a diagnosis.
Yep.
And
That's where the SUMP category ends up being a lot, right?
right. And sometimes, you know, you have area that looks more low grade and high grade. And so like, you know, like what category do you put it in there? And how often, I guess, in these scenarios, do you actually recommend intraoperative frozen section to help with management?
Yeah. So to some extent, that's going to depend on the site, right? Because, for example, you know, if it's a submandibular gland, yeah, surgery is probably not going to be very different. But as I referred to before with the parotid, it could have a significant impact intraoperatively. So there certainly can be a role for frozen section diagnosis of these tumors. You know, they can be challenging on frozens too. But you know, I think if we can't resolve that uncertainty on cytology, then I think it's quite reasonable to recommend a frozen section if there's some doubt. You may be able to resolve that uncertainty. With regard to, like, you know, where those types of aspirates are going to fall, you know, I think for what you're describing, you know, those are going to be aspirates. You know, what you're describing are aspirates where you know it's neoplastic, and you have uncertainty about whether it's benign or malignant. And that the two categories in Milan that would account for that really are the SUMP category and the suspicious for malignancy category. And really there, the thing that's going to make that distinction is, you know, whether you think it's more likely to be malignant or whether you think it's more likely to be benign. If you think it's more likely to be benign, then SUMP would be the more appropriate diagnosis. If you think it's more likely to be malignant, then I think suspicious would be the more appropriate diagnosis. I think in most instances, from a practical management perspective, that distinction between SUMP and suspicious probably doesn't matter very much. You still have the same degree of uncertainty there. The way it could matter, again, you know, it all depends. I think this is where, you know, you kind of go beyond just what the diagnostic headers are. You know, it's like, you know, is it SUMP or is it suspicious because you're not sure if you're dealing with an oncocytoma or an acinic cell carcinoma? Well, that's a very different scenario than saying it's SUMP or suspicious because I'm not sure if I'm dealing with a basal cell adenoma versus a solid variant of adenoid cystic carcinoma. And again, the distinction is really, you know, in one of those differentials, you're talking about a benign tumor versus a low-grade malignancy, and the surgical approaches are going to be similar. In the other instance, you're talking about a benign tumor versus a high-grade malignancy, and the surgical approaches might be quite different. And so I think, you know, it's going to vary depending on what your differential diagnosis is. And I think certainly in that latter scenario, where you're concerned about a high-grade malignancy, it may be more important in that circumstance to resort to something like an intraoperative frozen section to make that distinction.
Okay. Well, thank you so much for giving us this wonderful talk, especially during the time of COVID. And so we really appreciate you doing this, and we hope, you know, when the COVID clears, we'll be able to bring you here for an on-site visit.
I would love that. And, I appreciate everybody taking the time to join in. I know we're all a little zoomed out at this point. I know I am, but it's our new reality. So thank you for the invitation, and I do hope to have the opportunity to meet you all in person sometime in the near future.
Thank you, Jeff, and thanks everyone for tuning in.
Thank you.